You've just had a mammogram and biopsy for calcification. Maybe it was screening mammogram. And maybe you felt something. And now you are sitting with a piece of paper that has 3 words on it that you've been Googling ever since. Ductal carcinoma in situ. And everything you read has just made you more confused. Some websites call it a cancer. Others call it precancer. Some say you need surgery immediately. Others say it's massively overtreated. None of that is helpful, and none of that is the full picture. I'm Dr. Alex Popovich. I'm a breast surgeon, and I've been treating DCIS for well over a decade. And in this video, I want to give you what nobody gave you when you got that diagnosis. A clear, honest explanation of what DCIS actually is, what it isn't, and why the conversation around it is more nuanced than most doctors have time to explain in a 15-minute appointment. This is the video I wish every one of my patients could watch before they walked into my clinic. What is DCIS? What the words actually mean, because they matter. Ductal, it means it starts in the milk ducts. Those are the tiny little channels that carry milk from the lobules where milk is made down to the nipple. And the breast is full of them. Carcinoma. This is the word that frightens people, and reasonably so. Carcinoma means cancer cells. The cells in your duct have changed. Under a microscope, they look abnormal. They look like cancer cells. In situ, and this is crucial, in situ is Latin and it means in place. What that means is that these abnormal cells are sitting inside the duct. They haven't broken through the duct wall. They haven't invaded the surrounding breast tissue. They cannot spread to lymph nodes or anywhere else in your body. And that containment with that duct, that's everything. That's what makes DCIS fundamentally different from invasive breast cancer. Think of it this way. Invasive breast cancer is like a flooded river. It has gone outside of its boundaries. DCIS is like river that's swollen after the rain. It's much higher levels. It looks more raging and angry, but it hasn't spilled outside of its boundaries. DCIS is also called stage 0 breast cancer. And I call it precancer. It's not invasive. It's not life-threatening in the way that invasive breast cancer can be. And yet it is treated quite seriously in most cases. Because without treatment, some cases of DCIS will become invasive breast cancer. But the question that makes DCIS so complicated, and we're going to come back to this, is that we cannot yet reliably tell which one will progress to invasive cancer and which one would never have caused a problem at all. How is DCIS found? The vast majority of DCIS is found on screening mammogram. That's important to understand because it means that most women with DCIS have no symptoms whatsoever. No lump, no pain, no nipple discharge, nothing that could tell them that there was something wrong, that something was there. What shows up on a mammogram is usually microcalcifications. Tiny calcium deposits that form inside the duct as abnormal cells grow and die. They look like a cluster of fine white specks on mammogram image. A radiologist sees that cluster and flags it for further imaging as well as investigation. So the next step is usually a core biopsy, a needle biopsy under local anesthetic and imaging guidance, where a small sample of tissue is taken from the area and sent to a pathologist. And it's the pathologist's report that gives you the diagnosis. Very rarely, DCIS is found because someone has noticed a change in the breast, a lump or a nipple discharge, or sometimes a bit like eczema around the nipple. And in those cases, the DCIS may be more extensive. But for most women watching this video, the diagnosis came out of blue because they had routine screening mammogram. And that's actually good news. It means it was found early in a way that gives you options. When you get your biopsy result, you'll receive a pathology report. This report contains information that shape your entire treatment conversation. And most people find it completely incomprehensible. So let me decode the key parts. Grade. DCI is graded 1, 2, or 3, and in some countries like New Zealand, we tend to call it low grade, intermediate grade, and high grade. The grade reflects how abnormal the cells look under the microscope and how fast they're likely to grow. Low grade DCIS tends to grow slowly. High grade DCIS looks more aggressive under the microscope and tends to grow more quickly. Grade matters a great deal when your surgeon is talking to you about your timing options. Hormone receptor status. I want to flag something important for those of you watching from New Zealand or Australia. Unlike the United States and United Kingdom, where estrogen receptor testing of DCIS is routinely performed and recommended by national guidelines, in New Zealand and Australia, we do not routinely test DCIS for hormone receptor status. That means your pathology report may not include estrogen receptor status at all. And that's not an oversight. It simply reflects a different clinical approach. If you're watching from the United States or UK, your report will typically include whether the cells are estrogen receptor positive or negative, which determines whether hormone blocking therapy such as tamoxifen may be offered to reduce your future risk. And most DCIS is estrogen receptor positive. Comedonecrosis. This term refers to dead or dying cells within the duct, a sign that cells are growing so fast they are outstripping their blood supply. Comedonecrosis is usually associated with higher grade DCIS and slightly higher risk of progression to invasive breast cancer. Size and extent of DCIS. The mammogram or MRI report, not pathology report, will describe how large the area of DCIS appears to be. Size influences whether breast-conserving surgery like lumpectomy is feasible or whether mastectomy needs to be considered. I want to be honest with you, not all DCIS is the same. Two women can have DCIS and face very different conversation about their treatment because their grade, size, receptor status, and individual circumstances are different. And this is why generic internet searches are so frustrating, because the answer genuinely depends on your specific report of both pathology and imaging, as well as your situation. Is DCIS really a cancer? Now let's address the question that's probably been bothering you since you started Googling. Is DCIS actually cancer? Or isn't it? The honest answer is it depends on how you define cancer, and there is genuine debate about this. And here is what we know for certain. The cells are abnormal. Under the microscope, they look like cancer cells. And that's why pathologists use the word carcinoma. If we didn't treat DCIS at all, somewhere between 25 and 60% of cases, and that's quite a wide range, which reflects how much we genuinely don't know, would eventually progress to invasive breast cancer. And that's why it's taken seriously. But there is the other truth that I think patients deserve to hear. Most DCIS will never become invasive cancer. And right now, we don't have reliable enough tools to tell you with certainty whether yours is the one that would have progressed or the one that never would have caused you harm in your lifetime. And that uncertainty is real. It's not a failure of medicine, it's just where the science currently is. And it's a reason that researchers are running trials right now, including one called COMET trial, specifically designed to work out whether low-risk DCIS can be safely managed without immediate surgery. We'll still manage high-risk DCIS with surgery. What I can tell you is that the word cancer carries enormous weight, and understandably so. And I think the way DCIS is sometimes communicated to patients doesn't always reflect how different it is from invasive breast cancer that people rightly fear. You're not facing the same situation as someone with a stage 2 or stage 3 breast cancer, and that matters. And anyone treating you should be having that conversation with you honestly. What happens next? So what should you expect after a DCIS diagnosis? First, a surgical referral if you haven't already seen a surgeon. Your surgeon will review your imaging, your biopsy report, and your individual circumstances. They may request an MRI, particularly if you have dense breast tissue or if there is uncertainty about the extent of DCIS. The standard first treatment for DCIS is surgery, either a lumpectomy, where the area of DCIS and the margin of surrounding tissue is removed, or in some instances, mastectomy, where all of the breast tissue is removed. Which surgery is appropriate depends on the size and location of DCIS relative to your breast size and your own preferences. After breast-conserving surgery or lumpectomy, radiation therapy may be recommended to reduce the risk of DCIS coming back in that breast. After mastectomy, radiation is generally not needed. In some countries, particularly the US and UK, endocrine therapy such as tamoxifen or an aromatase inhibitor may be offered if the DCIS is ER positive to reduce long-term risk of invasive cancer. It's more as a prevention rather than a treatment of this DCIS. And this is why in New Zealand and Australia, this is not a routine practice for DCIS, although it may occasionally be discussed in a specific circumstances. Now, and this is important, for some women with low-grade, small-volume DCIS, active surveillance is beginning to be discussed as a potential option. This is still largely within the clinical trials, but it's a real conversation that is happening in specialist centers. If you have a low-grade DCIS and you want to understand all your options, it is absolutely reasonable to ask your surgeon about the evidence for active monitoring. And a key word here is conversation. You should be having real, informed conversation about what your particular DCIS means, what the options are, and what are the trade-offs of each. Not just being told what to do, but being helped to decide. DCIS is a diagnosis that deserves more honest, more nuanced conversation than it often gets. It's not nothing. The cells are abnormal, and in most cases they should be treated. But it is also not the same as invasive breast cancer, and you deserve to understand that distinction clearly. What I want you to leave this video with is this: you have time. DCIS is not a medical emergency. You have time to understand your diagnosis, to ask your questions, and to be part of the decision about what happens next. If there is one thing you do after watching this, let it be writing down 3 questions to bring for your next appointment. 1. What is my grade? 2. What is the size and extent of my DCIS? 3. What are all the treatment options for someone with my specific situation? In my next video, I'm going to go deeper into one of the hardest questions in breast surgery right now. Do you actually need treatment for DCIS? Because the evidence is more complicated than most people realize. And as a surgeon who treats this every week, it is a question that genuinely keeps me up at night. I'll link that video above when it's live. And if you found this helpful, please share it with someone who's just been diagnosed, because this is exactly the kind of clear information that is hard to find when you need it the most. I'll see you in the next video.